Some say there are things that we're never meant to know, mysteries better left ignored, strange places that ought never be explored. I don't think that applies to OB ultrasound. And this is a picture of Stonehenge. So what we're going to do now is we're going to start the tape. So this is an image of the fetal head. And obviously we're concentrating on the region of the lateral ventricle. That was an example of a choroid plexus cyst. Case 2. Placenta's posterior, but that's not what we're looking at. I draw your attention here. Color Doppler of the same case. And we're looking here. So that's an example of a two-vessel umbilical cord. So you have one artery and one vein. Case 3. This is the chest. We can see the ribs. We can see the heart beating here. So we're coming down to look at something that's abnormal in the abdomen. And we see this big cystic mass. And we've labeled this cystic second structure, the bladder. So we don't think this big cystic mass is the bladder. So we think it's part of the right kidney. And here we're trying to show you the left kidney. So that was an example of a UPJ, ureteropelvic junction obstruction. Case 4. This is labeled post-void, which gives you a hint. Why do we do post-void images? That says cervix. You can see the cervix here. This is a transverse image. We're scanning through the volume. So that was an example of placenta previa. Case 5, transvaginal ultrasound. You can see that we're getting a nice M-mode tracing. That's an example of a live ectopic pregnancy. Really no spontaneous body motion or cardiac activity. Color Doppler. M-mode tracing. So that was an example of fetal demise. Case 7, transverse image of the fetal head, magging it up. It says 12.6. It's 10.2. So that was an example of hydrocephalus. Sagittal transabdominal ultrasound image. There's an intrauterine fluid collection. We're measuring the size of the fluid collection. And this is a young woman with a positive pregnancy test. That says 20. And the next one, I think, says 18.6. Now it says 20. And if it's a gestational sac, it's over 7 weeks size. So that was an example of a blighted ovum. I guess we're not hearing the sound. It's a Doppler of the umbilical cord. You can see that there's venous flow. And the ratio here is 3.85. And it's showing you the ratio up here again, 3.85. So that's an example of an abnormal systolic to diastolic ratio, suggesting the possibility of IUGR. This will be case 10. We're looking at the uterus. And there's a complex mass filling the uterus. Mass is chiefly solid. It's got some cystic spaces. This is Doppler, color Doppler. That's an example of a mole. It's got more cystic spaces and more cystic areas than the slide that I showed earlier. But again, it's somewhere on that continuum. It isn't quite a cluster of grapes. Case 11. We can see the baby here. And what we're looking at is up here. So what we have is a complex hypoechoic cystic collection beneath the placenta. So that's an example of abruption. The next one isn't necessarily considered an anomaly, but it's sort of on the range of normal variance on the Bell curve. And we're looking at the amniotic fluid. You can see it's got diffuse internal echoes. In fact, the umbilical cord stands out quite sharply. So that's an example of vernix at the high end of the spectrum, and that's a normal variant. Case 13. This looks somewhat superficially similar to case 11, but it's not. You can see the baby moving, and we can see this membrane here, and we can see this collection. That was an example of a subchorionic bleed, a big one. Case 14, you have to look at relatively intently. This is posterior, this is anterior, and we're looking here. the baby's head. Now we're going to scan back down. That was a case of an omphalocele, and you could see the herniated contents covered by a membrane. And when the baby is moving, it can be quite difficult to make it out. Here's a transvaginal image, young woman with pelvic pain, and we see this mass at the edge of the uterus, and it looks like the endometrial stripe is coming right up to the mass. Color Doppler demonstrates considerable vascularity within the mass. There we go, we got the sound now. See that there's venous flow, arterial flow. So the question really was this a cornual pregnancy, or was this a fibroid? Turned out that that was a fibroid. And here's another example of the bigger the anomaly gets, sometimes the harder it is to tell what you're looking at. We're looking here, and then we're looking out at this thing extending. And if you were scanning yourself, you would know that this was the head. And here we're trying to show that. Here's the spine, cervical spine coming up. And we get into the head, and then we got this big cystic mass. Here's a linear array transducer trying to show fine detail within that cystic mass, and you can see the edge of the membrane here. Here we're tracing it back to the head. So that's an example of an encephalocele, and it was extending off of the occipital portion of the skull, which is common. This is case 17. The finding isn't subtle, but the etiology may be. And we're looking at the placenta. And the placenta does not appear normal. Color Doppler imaging. So there are multiple cystic areas within the placenta. So those were placental infarcts. This is case 18. This is a ultrasound procedure, transvaginal image. This is the uterus. We can see this rather heterogeneous, chiefly hyperechoic mass-like area in the uterus. And this is a hysterosonogram. So we're injecting sterile saline, and that's the balloon being deflated. And now you can see the injection of the saline. The hyperechoic stuff are little bubbles, but now we can see more of the anechoic fluid, and it's within the endometrial cavity, and it's surrounding this chiefly hyperechoic solid mass with some cystic spaces. Those little hyperechoic things floating around are bubbles. So that was an example of a large polyp as seen on hysterosonogram. Case 19, another procedure. So this is real-time monitoring of the needle from an amniocentesis.
When you look at a pediatric chest, it's important to remember that, especially in the very young children, you may be looking at children with malformations, syndromes, and dysplasias, especially in the very young. So you very carefully want to scan the bony structures and keep this in mind. For those of you who have never seen a double manubrial ossification center, you have one right here, and that can be a normal variant and is a normal variant in about 10% of the population, but is also seen in children with trisomy 21. So if you were to see that in a child who had congenital heart disease, a big heart, or some other manifestation of trisomy 21, 11 ribs or 13 ribs, you'd be home with a diagnosis. A child such as this, born with multiple rib fractures, an acute fracture of the humerus, might also have foreshortened, curved femora, is an indication that this child is born with osteogenesis imperfecta. This is a skeletal dysplasia that you may not recognize per se, but when you looked at it with the narrowed metaphyses and the oar-shaped ribs, you would be able to get enough information by looking at the study and talking to your clinicians that you would be able to put this in a category. This is one of the mucopolysaccharidoses. And a child with such narrow chest, very peculiar looking bones, having a lot of respiratory distress, the very curved, shortened femurs that almost look like the femurs that you see with osteogenesis imperfecta, is a child with thanatophoric dwarfism. But you could go through the book and look and say, okay, what other short-ribbed dwarfisms are there? Does this child have polydactyly, syndactyly, normal number of fingers, etc.? When you see a differential density of the chest in adults, the first thing you think of is a mastectomy. When you think of it in children, you should think about something else along the chest wall. This is agenesis of the pectoralis muscle, and this child also has an abnormality, as you can see, of the upper limb. This is a manifestation of Poland's syndrome. Another cardiomelic syndrome, if the heart were big and you saw unilateral involvement either left or right, you would think of Holt-Oram syndrome, which is an autosomal dominant. Poland's syndrome is much more common on the right than the left. And if the bones were normal, then you could go to other things that cause differential densities in the lungs or pleura themselves. Acquired things, such as nutritional, when the ribs are all confluent in the front like this, you could palpate it, it'd be lots of little bumps. This is a rachitic rosary, and you might ask for just a localized film of either the knee or wrist. Because the knees and wrists are fast-growing segments, they will manifest nutritional disorders or other systemic disorders, lead poisoning, for example, much more quickly than sites that don't have rapid growth. You don't need to do a skeletal survey. Any one rapid-growing joint will show the cupped metaphyseal changes. There's a fraying of the border. You get a delay in ossification, a delayed bone age associated with this. A patient with a central line and abnormal humeral heads, for example, this could be radiation-induced change. It is an avascular necrosis. Other causes of avascular necrosis in childhood could be a child who's already had a renal transplant, or as in this patient, a child with sickle cell disease, a late teenage child. These same patients can have a large heart due to a high output failure. If you see an area of infiltrator atelectasis in a patient with bony changes of sickle cell disease, you do have to worry about acute chest syndrome. The tips from the tubes, from the catheters, you look very carefully. If you notice there's an endotracheal tube, then you also look at the NG tube. Now you're saying there's gas down here, but that tube isn't making it down. Perhaps they've had a traumatic passage of a catheter. That can happen. You can wind up tearing the upper esophagus. But when you see all of these abnormalities in the vertebral bodies, cleft vertebral bodies, another cleft vertebral body, two examples of congenital bar deformities, which will increase scoliosis as the patient grows, you begin to think of Vater or vactoral associations, vertebral, anorectal, cardiac, tracheoesophageal, renal and limb anomalies. In this case, because you've got the esophagus ending here and the air distally, you know you have the most common form of esophageal atresia, where the trachea has given off a fistula to the stomach, and that's the most common kind, seen in about 80 to 85% of patients with esophageal atresia. This child has also been intubated and has a very peculiar gas collection. In this instance, you do have an abnormal collection of gas due to a traumatic intubation. Okay. An old pixely kind of slide, an abnormal kind of, an unusual kind of endotracheal tube because the child had tracheal abnormalities. The abnormally positioned vascular catheter should make you at least suspicious that something is going on unusually in the mediastinum. This is an example of what a tube in a left-sided superior vena cava looks like. A left-sided superior vena cava can be a normal variant, but it's an uncommon normal variant. It's seen in about 10% of patients who have tetralogy of Fallot. So if you saw this, for example, in association with a child that had diminished blood supply or a right aortic arch, you would again be moving towards a diagnosis. This is a little more subtle. Here's a child, and we put a little bit more of the abdomen in than I've been showing you because the cardiac apex is on one side and the NG tube is going across the midline. And I don't want to tread too much on anybody else's turf. I know they're doing cardiac this afternoon. But when you see not a total situs inversus where both things are flipped, but the cardiac apex, and by definition some of the things within the chest and the abdomen are flipped, you have to think of heterotaxy syndromes, polysplenias, asplenias, sometimes a little bit of both. The polysplenias have multiple spleens. This is an example of just a heterotaxy without a specific name. You can look at the branching of the trachea. You can look for bilateral minor fissures, which I'm going to show you coming up. The contrast study demonstrates that the stomach is on the wrong side, that there is some malrotation, that the duodenum does not have a normal sweep, and that is indeed liver coming transversely across the abdomen. And as is typical in patients with asplenia, the aorta and the inferior vena cava are on the same side of the spine. They may be on the left or they may be on the right, but they're both on the same side. Okay. Thymus is something that kids have. It tends to look less prominent with age. In most children, the right lobe is more prominent than the left lobe. The thymus can rebound after stress and get quite large. It's quite large in a lot of neonates. It can actually become a posterior mediastinal mass as well. The thymus is a soft organ, and therefore when it's very large, you may see indentation, scalloping along its borders where the ribs indent it. It can be lifted up. So if you have this little angel-like appearance, that's an example of a pneumomediastinum, and this is demonstrating the left and right lobes of the thymus gland very clearly. The thymus can enlarge after stress. It can enlarge in children with hypo or hyperthyroid syndromes, and it can increase, and this is a large cardiothymic shadow, and that's a term a lot of pediatric radiologists use because it's sometimes difficult to distinguish the contour of the thymus from the heart, and you would go through a differential about cardiac enlargement, pericardial disease. This turns out to be thymus in a child with HIV positive disease. The children get lymphoepithelial cells, cysts, and this is an ultrasound. Since the gland was so big, you could come right up against under the ribs and under the sternum and image it, and it was filled with a lot of these little cysts, the same way that children will have lymphoepithelial cysts in their enlarged parotid glands. The thymus also participates in this process. You can have ectopic thyroid. Some patients that may be their only thyroid. You can have a teratoma. And this is a local case that made the circuit years ago, a patient who at 5 months had a very prominent left mediastinal fullness. It was in the anterior mediastinum. It has no calcifications. It looks like a nice, juicy, hunky thymus in a lot of kids. When the child came back 7 months later, there was a huge mass. The trachea at this point was deviated posteriorly. It was deviated to the left. There are a few calcifications within it, and this is now an example of a teratoma. Was there a teratoma there before? Should every child with a thymus this size be followed up? The general feeling is that this child is entitled to a thymus this size, but he certainly probably falls at the far end of the normal thymus spectrum. Patients can have lymphoma in that same space, anterior mediastinum or middle mediastinum. In this patient, the mass is doesn't look that prominent. This, by the way, is a little artifact, not a clip. You can see some fullness in the retrosternum. In an older patient, that retrosternal fullness becomes lucent like an adult. I think what's dramatic about this child who had superior vena cava syndrome is that when the contrast bolus was given from the right arm, you could see the mass, you could see the vessels coming up from the aorta, and what happened was that the superior vena cava did not fill, but the other cuts in between demonstrated contrast coming around, and the superior vena cava was reconstituted by blood coming across the azygos and hemiazygos system along the way. So superior vena cava syndrome being produced by a non-Hodgkin's lymphoma in this child, even though the chest film doesn't give you an example of that much mass. The mass was just very strategically positioned. Something that simulates this and is just a typical left upper lobe atelectasis. In this case, you've got the density going from the base of the lung down by the diaphragm up. It's very clearly defined because you've got the edge of the major fissure. It's a lovely demonstration of how far up the superior lobe of the superior segment of the lower lobe can come. But in many ways, this looks like a much more worrisome film on the frontal than the last one did here. Okay. You can have other masses at the thoracic base. I've seen a child who had a pericardial cyst that looked like this. I've seen sequestrations that look like this. The tip-off in this child is that there's a little bit of gas higher than it ought to be. And while most of the hernias, and we're going to show some, are in the back, and I refer to as Bachdolect, this little piece of gas coming up in the front tells you that there's some discontinuity in the anterior portion of the diaphragm, and this then is a foramen of Morgagni hernia, and we've got liver coming up into that region. So that's what the soft tissue density is. Ultrasound can be used for a lot of these lesions in children. The children are so small, the transducers fit large parts of their body so that you can see liver. You can get a lot of land, so to speak, in a child of this age. In the middle mediastinum, there's bronchogenic cysts. They can cause hyperinflation. They can cause splaying of the carina. The person who's going to talk to you about cardiac will probably show you a pulmonary sling that can do the same thing in terms of hyperinflation, in terms of pushing the trachea anteriorly. That would be in your differential. The bronchogenic cyst and GI duplication are both foregut abnormalities. The only difference between them is the lining of the structure. Occasionally, the material will become very thick and proteinaceous, so the Hounsfield units numbers can vary. If it's a very older patient, in fact, we've seen these in adults, you can actually develop calcification in the walls over a period of time. Some of these become quite large, almost looking like a gram-negative pneumonia, almost looking like some of the other tumors in the chest. On the other hand, there's absolutely no rib destruction involved at this time. There's no calcifications within it. So you're less likely to think of a primitive neuroectodermal tumor or a very unusual neuroblastoma. The CT of this demonstrates a large fluid-filled multiple cystic structure, much larger than the last lesion. A lot of the chest CTs, a lot of the belly CTs are going to look a lot more pixely in children. Because of the concern about radiation in children, the trend has been to use very low MAS. Even with the rapid scanning, you wind up with a diagnostic scan, although this is actually an older study. You wind up with a diagnostic scan not as pretty as a lot of you are going to be used to looking at in the older journals. You're going to see sort of grainier, more pixely images. Lymphoma can be in the middle mediastinum as well, and there are a few other foregut abnormalities. In this child, there's aeration of one lung. The other lung is very opacified. There's a little air collection. And this is a child who had a foregut abnormality where the trachea to the bronchus to the right lung came off the distal esophagus. This was not a salvageable situation in terms of the right lung. Other things in the middle mediastinum: infectious diseases, sarcoidosis. This young woman came in over the weekend, had erythema nodosum, which is really just a form of paniculitis. If you go out and Google erythema nodosum, it tells you that you can have lymphoma with it, but it's frequently seen also in association with reactivation TB, also with sarcoidosis. Her chest study looked like this. So everything that lives in the middle mediastinum does not have to be lymphoma. You should still remember that there are infectious and non-infectious processes. Cardiac assessment, we're going to tread lightly because, as I said, there is a different talk on it, but you should look at size and shape and situs. And just so that you'll be reinforced, if you haven't seen a right aortic arch in a while, there is one. If you'd like to see a patient with bilateral minor fissures and a patient with a cardiac apex and stomach bubble are on opposite sides, but different from the last patient. This is a child with asplenia. This is a child who has either mirror image branching, which would bring him into the cyanotic heart disease, or non-mirror image branching, which would bring him into a more normal group of children with the right aortic arch. And those are little buzzwords to keep in mind. The superior mediastinum can also be a little wide with non-mass-like lesions. If you notice, the heart here is normal, but the vessels are a little prominent. If you remember the term snowman or figure of 8, that calls to mind patients who have total anomalous pulmonary venous return with a vertical vein, supracardiac drainage of the common pulmonary vein, the vertical vein, into the superior vena cava. And it can give you this contour looking a little bit like lymphadenopathy, but the tip-off is that the vessels are up, and you can have an azygous vein, and in some patients you'll have that extra fissure in the right upper lobe. Patent ductus arteriosus, and I thought this was sort of my turf. Little babies who are premature have granular lungs with a surfactant. Their lungs do much better than they used to do, but they do have a tendency to open up the ductus arteriosus. It closes physiologically. If you have a baby whose lungs look good one day and go south the next day, there is a differential for this. Some of these babies bleed into their lungs. Some of these babies open their patent ductus arteriosus, or they open the ductus and they flood their lungs with blood in that sense. A lot of the preemies are stressed, and their corticosteroid levels drop precipitously, and they actually become a little bit leaky or weepy into their lungs. Many neonatal units will actually give prophylactic corticosteroids on day 4 or 7 of life in an attempt to just avert this process that they have to then correct secondarily. A little clip in the mediastinum is an indication that the patient has had a repair of a patent ductus arteriosus. Transient tachypnea of the newborn goes the other way. It's a baby that has a little respiratory distress at birth. The lungs may not be particularly dramatic, slightly granular. They have indistinct cardiac borders. And the test of time is what tells what's going on. Within 24 hours, these children are breathing well on their own, the lungs are clear, and they are generally discharged very quickly. If you have a question whether something is transient tachypnea versus RDS, you, as I said, you have time on your hands. You can wait 24 hours. You can get an idea of how big the baby is. One other thing that can cause a density in the lungs, which will clear rather rapidly in the immediate perinatal period, is that these babies are instilled with surfactant, artificial surfactant, and it goes in and it lowers the opening pressures of the small airways, so we see much less barotrauma than we used to. The children, rather than being on high volume ventilators, are on little oscillators, and it keeps the lungs well aerated. Meconium aspiration is also seen in neonates, but it's at the other end of life. These are the very large babies. These are generally term or post-term babies, and the pattern is much coarser. These are two different children. You see something that's coarse, it may be a little bit more asymmetrical. These children are prone to barotrauma because you do have to work to keep the lungs open. Since they're term, 80% of them will have an ossific nucleus up in their humeral head. People are trying things like surfactant to see if they can wash out the lungs. Sometimes they put on extracorporeal membrane oxygenation while the lungs clear themselves out. In the posterior mediastinum, there's ectopic kidneys, neuroenteric cysts. Diaphragmatic hernias are sort of everywhere, so we're going to get to those later. And neural-aged neuroblastomas, ganglioneuroblastomas, ganglioneuromas are also in the posterior mediastinum. There are a host of congenital lung anomalies. Many of them, most of them now, are diagnosed prenatally. They are suspected on the basis of ultrasound, and then additional imaging is performed. This child is the first child that I've ever had the advantage to see prenatally, and the increased area, these very bright areas, are actually bilateral congenital cystic adenomatoid malformations. In contrast to sequestrations, which are generally at the bases, or lobar emphysema, which we'll talk about, these can be in any segment. The prenatal diagnosis can aid in treatment because there is certain treatments that's performed. One of the main differentiating criteria is what the abdomen looks like. Are there normal abdominal contents present? We're going to go through that at the end. They're given 3 kinds, depending upon whether they're more solid or more cystic. If they're not diagnosed prenatally, they're picked up after birth because the child, because of compressed normal lung, may have respiratory distress because they themselves can become secondarily infected. Sometimes the child is asymptomatic. If they're very large and are causing ipsilateral and contralateral hypoplasia of the lung, they may be tapped or they may be drained. There's only a few centers in the country that are doing this. They feel that this gives the lungs a chance to grow normally. And you can also get, as it says here, hydrops and maternal preeclampsia from the CCAM. They can be quite air-filled, as this one, which also has a very large solid component. Despite the size of this child does not have as much mediastinal shift as some of the others that I will show you. This one is much more solid, and the cysts are filled with fluid, again, not taking up quite as much space in the lung as some of the others. These, I said, are all segments, so we've shown a couple of right-sided ones. What do we know? Both postnatally and prenatally, they'll decrease in size. That when you look at the pathologic literature, all of these malformations sort of come across a spectrum. Some are very pure, and some of these will have a manifestation of another process, such as you could have a CCAM with a vessel coming from the aorta, which would make you think of a sequestration, or you might have a little bit of pleura around it, which would make you think of a sequestration. So they're not all totally pure lesions. Some people like to take them out because even though they themselves are not malignant, sometimes there's a malignant tumor somewhere else in the lung. I'm not quite sure of the rationale for that. Again, a recent case diagnosed prenatally, and in this case the child does have mediastinal shift. And we've been following this child now, he's 18 months old, to see if it involutes at all. He's growing well, he's asymptomatic, hasn't really changed size, but if it doesn't grow, it may proportionally become less of his lung. The slide on the left and the slide on the right look remarkably similar, except not quite. In this child, you're seeing a lot of air space, or a lot of air collections, and a lot of intestines below the abdomen. In the child on the other side, the nasoenteric tube is coming up, and it's coming into the thorax over there, and you can see the bowel gas is in continuity with this. The child on the right has the diaphragmatic hernia. The child on the left has the CCAM, but in essence, the pathophysiology is the same. They each have compressed the ipsilateral lung. They each have shifted the mediastinum from one side to the other and have resulted in contralateral lung hypoplasia. They both would, in this instance, be surgical, neonatal surgical emergencies. I'll let you read it. Read it faster than I can do it. Okay. Sequestrations tend to be at the base. You might just see a little density like this. Sometimes it's a little density sitting out a little bit further. It doesn't usually compress lung. It usually doesn't have much of it. It may be hidden in children who have respiratory distress syndrome. It may take a while to be seen. Intralobar more common. As I said, they overlap with other things. Surprisingly, 50-50 left and right, etc. The ones that are below the diaphragm are very interesting. They, of course, tend to be extralobar. They are seen prenatally, generally as suprarenal masses that have a very bright intensity. They can involute in utero, and that's one of the dilemmas of the disappearing suprarenal mass. And they have a blood supply coming off of the aorta. Knowing this, you can image the child with Doppler ultrasound. Using color Doppler, you can look for the feeding vessel. That helps you make the diagnosis. You can do contrast-enhanced CT. We generally don't do MR just because it requires sedation. It takes a lot longer for the child. With the old CT scanners, we used to scan from bottom up. With the new 16 detector scanners and babies this size, since we can go through their chest in 2.5 seconds, doesn't matter if you go bottoms up or top to bottom. So we don't use the strategy that we used to use for scanning, but we can use any of these techniques to look for the abnormal blood supply. This is one that didn't have an abnormal blood supply with a lot of artifact from leads. We kept looking for it. Similarly, you could look with Doppler, trying to find the colored vessel, how much blood supply is within it, how much blood supply is not within it. This was taken out in what's called a sequestration, although we never did find a nice feeding vessel. But only 80% have a vessel off of the aorta. Bilateral hypoplasia, not agenesis. Difficult to live, but some people do, with diaphragmatic hernias, CCAM, and severe renal abnormalities. And that's a different pathophysiologic chain. If you don't make enough urine, you have a lot of compression of your chest, not enough amniotic fluid, and you can have a very narrow thorax, even though the lungs are intrinsically normal, and you can have respiratory distress. Lobar emphysema, fairly uncommon. I've been doing this 22 years, and I think I've seen about 3 cases, but it's fairly classic, something you should be able to recognize. One segment becomes very lucent. If the child were a bit older, you would begin to worry about a foreign body. Since children under the age of 6 or 7 months do not have the ability to pick up and put things in their mouth, you don't think about foreign bodies unless there's an older sibling. This is a very typical location as well. CT demonstrates that you have this very lucent lung segment, but you don't have a lot of disordered parenchyma within it, as you might with some of the other abnormalities. The CCAMs, for example, had a lot of parenchyma disordered, a lot of density. Here you just have a lot of lucency and stretched out vascular markings. It's a favored segment, so somebody's going to show you that. If you're lucky, you'll see it in a favored segment, but you can think about it in any other segment. And you have congenital heart defects in association with it, so when you see it, you should tell the clinicians to listen very hard the next time they see the child. Cysts within the lung are very rare on a congenital basis. This is actually already a 3-year-old child. They can be seen in children who have had prenatal problems or perinatal problems, such as pneumatoceles developing after bronchopulmonary dysplasia, children with meconium aspiration, or after infections. But there are very few simple, single congenital cysts. In terms of abnormalities of the lung that are visible on plain film, again, a little bit of unilateral hypoplasia, the shift of the mediastinum from left to right, because these are always right-sided. You have differential aeration within the lung because it's not well formed. Lobar, you have an abnormality of the bronchial tree, the abnormal draining veins, looking like a curved scimitar or a sword from the Middle East, can be demonstrated. Generally on a plain film you see them. If you have a CT, you can see them a little bit better. The increased density behind the sternum used to be called an accessory diaphragm, but it really is just some of this repositioned mediastinal tissue as the mediastinum gets shifted from the left to the right. You can have unilateral pulmonary agenesis. It's usually associated with agenesis of the pulmonary artery. It's a diagnosis of exclusion. You would be looking on a CT to follow the tracheobronchial tree down to look at the pulmonary artery. It's sometimes seen in association with abnormalities of the vertebral bodies. This child has another abnormality. He's got a ventriculoperitoneal shunt tube in place. And you would want to exclude occluding lesions or intraluminal obstructing lesions. It is seen in a higher association, again, in children who have the Vacteural or Vater association. a moment on diaphragmatic hernias. They are going to be air-filled. The children will have scaphoid abdomens. You can look at the tube. And if the stomach is in the thorax, it's a much poorer prognosis than if it's other bowel loops. And I think it just indicates the extreme volume of what's in there. Okay. What we know is that the majority are left-sided. The left-sided ones also tend to do better than the right-sided ones, that you have these problems that we had already talked about. And this is something different. This is sort of an abnormality that develops in the lungs secondary to this increased density. You see this double density over the upper abdomen, and the diaphragms are pulled down. If a child has a giant omphalocele, the lungs and the thorax become hypoplastic. Now, if they try to repair it and they push this back in, the child will have respiratory distress as the diaphragms are driven up. And these lungs, at least for the first couple of years of life, as the child has very minor viral illnesses that other children will tolerate, this child may do very poorly with very, very minor illnesses. But the double density that we're seeing here is the omphalocele. A double density could also be a child sitting on a meningomyelocele. So you have to keep those two different things in your differential. But the child with a meningomyelocele would have the diaphragms up at the normal position. Round pneumonia is a particular pediatric condition. Looks like a tumor, scares people all the time because of that. We're fortunate in pediatrics in that there aren't very many lung tumors. We don't have a big population of smokers anymore. Most of the tumors that kids get do not metastasize to the thorax. The ones that do are generally detected in a stage before they metastasize to the thorax. So if you look at the big tumors like Wilms tumors that are 3, 4, 5 per million, which is one of the most common abdominal tumors, most of those are picked up at stage 1 or 2 long before they metastasize. So when you see a big round fluid-filled thing in the chest, you can be a little bit more calm about it, especially if it's sitting in the posterior segment and the child's sitting there with a white count and a fever. The ER docs love these because they know pretty much what the organism is. It tends to be one of the gram-positive cocci, so they know how to treat it. Looks like this. But it can be paraspinal and simulate a paraspinal mass. I've seen that. It can be down in the posterior sulcus and look like a posterior mediastinal process, but it's extremely round. You don't look for air bronchograms in it. We're not sure why children have this kind of a tumor, whether it's they get brought in very early, whether it has something to do with the collateral channels that we know are present. Just a pediatric thing. Another example. Okay. When we look at pneumonias or infiltrates, we try to decide, are they in a single segment, are they multiple? When I'm dictating, I always look for lymphadenopathy or effusion because that may take me a little bit further down the road. It's very difficult for us radiologically to differentiate between asthma and viral illness. We differentiate chlamydia just by the child's age. If you're born through an infected birth canal with chlamydia trachomonas, you may have it. Some people were treating those children prophylactically with erythromycin if they knew the child had been born through an infected birth canal. The problem with the treatment, according to the literature, is that it has an increased incidence of inducing pyloric stenosis. So the move now is not to treat prophylactically for children that are born through an infected canal, but wait and treat those that become symptomatic with conjunctivitis or with the pneumonia. They have this little raspy cough. Mycoplasma is a rather ubiquitous organism, causes a lot of pneumonia, but one of the most favored age groups is between the first and second decades. You don't see it, though, under the age of 4. So that's something that you have to think about in the pediatric population. It may look a lot like viral, a lot of segments. We still see tuberculosis, not a lot of it. I took the TB slide out. And if you have a child that was a preemie at birth, it becomes very difficult unless the mother walks in with his old film, or unless you have access to the old films, to know sometimes what's acute and what's old. Asthma can develop, or atelectasis can develop and clear very quickly. So if you have a child that goes from this to this or from this to this quickly, meaning within 24 hours, you're thinking about atelectasis rather than a pneumonia. You think about asthma. Other hallmarks of asthma and viral illness would be hyperinflation of the lungs and peribronchial coughing. If the child has chlamydia, you just get this multiple areas of vaguely increased density. The heart borders in this child are indistinct. Perhaps there's nothing specific about it. Maybe it looks much like what the textbooks used to call pertussis, but it's the age, the accompanying symptoms, and the radiographic picture that take you to the final diagnosis. That is actually miliary tuberculosis, and it can be acquired transplacentally, it can be acquired through a birth canal, it can be acquired through breast milk, it can be acquired through contact with an infected parent or caregiver, and this was miliary tuberculosis. Multiple lung nodules occur, not as commonly as in adults. You can go through the usual stuff in terms of septic emboli and coccidiomycosis and rheumatoid nodules. Don't see a lot of those. In children, you have to remember there's a couple entities that will present that way. Eosinophilic granuloma does, but eosinophilic granuloma can also present as discrete infiltrates, and after a while, honeycombing of the lung, of loose reticular pattern, frequently more commonly seen at the base, and respiratory papillomatosis, which I'm going to demonstrate. This is a child who started off being born through an infected birth canal where there's human papillomavirus. Most of the children born through those canals do well. A few of them will get vocal cord nodules or papillomas, which are then lasered off. Most of the children who have them lasered off do very well. Also, they either recur in a small percent and a very small percent. Those little nodules or a few cells get inhaled and they set up house down in the lungs. And in this child, you can see these little nodules. And on the CT, you can see the nodules and the areas of confluent density. These are actually treated surgically. If the child has so many that the surgery is going to be devastating in terms of respiratory function, they're given actual chemotherapy with methotrexate. We're going to close with just looking at a few slides on CF. It's very common, although now with gene testing we may be seeing less of it. Some of these children are being pre-selected. You can pre-select an embryo that does not have it. You can be gene tested in utero, so we may see less children born, but there's always the first child in any family. Some of them present as a neonate because of problems in the GI tract. Meconium ileus is when that thick meconium gets stuck down by the terminal ileum, causes a microcolon, causes a lot of GI distension. Peritonitis is if the meconium spills out, and that can occur with or without cystic fibrosis. And a meconium plug, which is meconium stuck down in the distal colon. Generally, it's a benign process not associated with cystic fibrosis, but 10% of the patients with meconium plug will have cystic fibrosis. What you see is a child who initially may just have recurrent right upper lobe disease, and it makes you think of an anatomic lesion. Is there a strange vessel? Is there a lymph node? Is there something? Why does this child keep getting right upper lobe infiltrate or atelectasis that clears? Over a period of time, that segment becomes increasingly diseased. And in the older patients that are coughing up blood, the differential includes, do they have varices that they're bleeding from, or are they coughing up blood from the GI tract? The first site that the angiographer will look at in terms of something to embolize or something to be removed is the right upper lobe, because this chronic inflammatory process will bring in vessels that will then bleed over time. You can get mucus impaction, and then you have these little very dense areas. The impaction, if it becomes secondarily infected, can cause bronchiectasis. The bronchiectasis can progress and cause large cystic spaces that become confluent. This is a thickened wall, a bronchiectatic space. This is subpleural. collections of air. These children can develop pneumothoraces spontaneously. When I was in training, they said you don't get a pneumothorax unless you're on a respirator. Not true. They can develop these spontaneously. Some of these cavities will become secondarily infected. We're seeing more and more children at the later end of life. There are actually now many adults walking with this disease because the treatment has become so much more effective. But they may have a markedly abnormal study such as this, showing focal areas of just mucus plugging, some bronchiectasis, and cyst formation. Thank you.
Today I'm going to talk to you about the pediatric airway. You already received a handout which roughly but not exactly follows the talk, so I'm going to recommend you put it away and just try to get a look at the images here. There's a lot of information to be presented and even more that could be given to you. However, I've chosen these areas because they've been known to show up on oral boards, even though some of them are rare and unusual. I understand some of you are here for just a general review, and I think this will probably also be helpful in your practice. For those of you who are taking oral boards, your knowledge is important, but your ability to recognize images and patterns is probably even more important. Remember to ask for another projection or imaging modality if you're not sure what you're looking at. Don't give a laundry list of differentials, keep it short and simple. If you suggest a diagnosis, which is unlikely, and you're just throwing it out to try to give a complete differential, you may be asked to defend it, and you don't want to waste the time trying to explain something you don't remember that much about. So why are airway films ordered? Stridor is the most common indicator for radiologic evaluation of the airway. The upper airway is also evaluated for neck mass, foreign body, which is not always opaque, epistaxis, nasal obstruction, lymphoid hypertrophy, possible vascular anomalies, trauma, and chemical ingestion, among others. Radiologic imaging techniques obtain two films, generally known as soft tissue neck, and use high KV and filters to reduce the prominence of bony structures and accentuate soft tissue detail. The AP film is taken during inspiration and phonation. It shows closed vocal cords and the immediate subglottic area. The arrows show the normal subglottic shoulders. The lateral neck is taken in full inspiration with the neck extended, include the nasopharynx to the trachea. The double white arrows show normal area epiglottic folds, and the single black arrow shows the outline of the epiglottis, which is normal in this case. Additional imaging techniques for more complete evaluation also consider AP and lateral chest, including the upper airway in full inspiration. Airway fluoroscopy should be considered if radiographs are not helpful in cases of inspiratory stridor. Barium esophagram may be helpful in cases of suspected vascular rings, which are even more elegantly demonstrated by CTA or MRI. So let's take a look at some cases. On a frontal chest radiograph, the trachea is generally a well-visualized gas structure, and it's tubular. It often is buckled to the right of the midline. This film is not abnormal, as the trachea may be seen buckled if the head is dropped towards the chest, or just in general in babies, as they are not able to follow instructions, obviously, or phonate on expiration. Apparent prominence of the retropharyngeal soft tissues may not be abnormal and may be secondary to positioning, swallowing, expiration, neck flexion, or oblique positioning. In general, the width of the retropharyngeal soft tissues are measured in inspiration at the level of C2 to C3 with respect to the vertebral body of C2. This ratio ranges from approximately 1 under the age of 1 to about 0.4 at the age of 6 to 10. So expiration, inspiration, and these are just changes in the airway with breathing. Coronal CT through the airway and through the sinuses. Please note here on the left this calcific density, which has been removed pathologically, and this is just secretions which have calcified over time and become arhinolinth. Sometimes there is a nidus for formation, and sometimes kids will just stick things up their nose. Anybody who has a small child will know that. Three films here. This is a benign, vascular, locally invasive mass located posteriorly in the nasal cavity. It occurs almost exclusively in adolescent boys. Presentation is often with epistaxis or nasal obstruction. Radiographic imaging shows anterior bowing of the posterior wall of the maxillary antrum, displacement of the nasal septum, such as in this case on the CT, and or a large soft tissue mass in the nasal pharynx that can be associated with erosion of the surrounding tissues. It's surrounded mainly by the internal maxillary artery as seen on the angiogram. Embolization is recommended before resection, and the recurrence rate is 25 to 30%. If given the first film at boards, please ask for another projection because you will probably be given the first film and a chance to biopsy this. Remember, you have to show that you're safe, and if you're not sure of what you're looking at, ask for another projection and another modality. This is an angiofibroma. Two films here show the most common congenital abnormality causing nasal obstruction. It may be unilateral, as on the left here, bilateral as on the right over here. Many unilateral cases are probably never diagnosed. It's bilateral in about 30%. Examination on the left is a unilateral bony condition, the one on the right bilateral membranous, and this is choanal atresia. Coronal and sagittal views of the brain and face. The arrow down here is pointing to a nasoencephalocele. It's rare, but you may see it, and once again, you may be offered to biopsy it. Please decline. These findings are secondary to inflammatory infectious etiologies: beta hemolytic streptococcus, rubiola, Epstein-Barr virus, Coxsackie virus, and adenovirus. These may enlarge and obstruct the nasopharynx and or eustachian tubes. The finding on the left is secondary to a mass in the posterior nasopharynx, secondary to enlarged adenoids, or the finding on the right is secondary to a mass at the end of the uvula, secondary to palatine tonsils. And this is lymphoid tissue hypertrophy, very common. Next finding, just a large mass in the mouth. This is a large tongue secondary to Beckwith-Wiedemann syndrome, macroglossia, which may also be seen in Down syndrome. Finding on the left marks a mass at the base of the tongue, seen on a nuclear medicine examination. A similar finding. Remember that this structure starts at the base of the tongue, at the foramen cecum, and in most of us descends over time. This is a lingual thyroid, a mass at the base of the tongue. Many of these are non-functional. Some of them are partially functional. A few of them are completely functional. The differential includes a thyroglossal duct cyst and an hemangioma. This finding can be life-threatening and is most often caused by Haemophilus influenza type B, although it is rarely seen nowadays. The child presents with a high fever, dysphagia, drooling, and a sore throat, and consciously tries to stay in an upright position with the head held forward and the tongue protruding. Peak incidence is roughly between 3 and 6 years of age. It's treated with intubation of usually 24 to 48 hours and appropriate antibiotics in many cases. Imaging is upright, and lateral projection is key, as approximately 25% are indistinguishable from another entity on the AP view with narrowing of the airway. There's an enlarged hypopharynx with a raised tongue. The larynx goes down and the retropharyngeal soft tissues flatten. The valleculi are barely visible or identifiable because the epiglottis swells and the epiglottic folds thicken, which is the real reason for stridor and dysphagia. And this swelling is what causes the epiglottis thumb sign seen on imaging. That's epiglottitis. This finding is the most common cause of upper airway obstruction in children between 6 months and 3 years of age. The condition is usually viral, often parainfluenza or respiratory syncytial virus. The child has a barking cough and stridor and an upper respiratory tract infection. The condition is usually self-limited to 3 to 7 days duration and rarely requires hospitalization or intubation. Soft tissue radiographs of the neck. The AP is key, and it shows distension of the hypopharynx, a normal epiglottis, seen here on the lateral projection, a symmetric subglottic narrowing as evidenced by an inverted V or steeple sign, as opposed to the normal shouldering, and this is croup. A soft tissue mass causing impingement upon the airway. Same findings seen on a cross-sectional examination of a CT, and sometimes findings seen in the lungs. Cystic changes as well, which tend to progress over time. This is an aggressive but histologically benign lesion that is seen before about age 7 and is the most common laryngeal tumor. The lesions may prolapse into the subglottic region and rarely spread into the lungs. It's usually secondary or been known to be secondary to human papillomavirus and maternal condyloma acuminoma of the cervix or vagina have been reported in the maternal parent of these patients about half the time, and this is papillomatosis. The arrow in question should actually be pointing to this mass, which is partially impinging upon the airway. You can see it posteriorly here, narrowing the airway and enhancing on the reconstruction CT and enhancing mass posteriorly in the airway. This is the most common subglottic soft tissue mass causing upper respiratory tract obstruction. It often arises from the posterior or lateral wall of the airway, and this is an hemangioma. Here on the left, we see unilateral air trapping secondary to a check valve mechanism causing overinflation or hyperlucency in an affected lung, which is accentuated in the expiratory condition, shift away from the affected side, or also remaining inflation on a decubitus view. Fluoroscopy may be helpful in some of these cases. And a schematic showing once again a foreign body in the right bronchus, a lucent overinflated lung, also seen on expiratory, The same finding is seen with the dependent lung, and this is a foreign body in the right bronchus. Foreign bodies inhaled, the findings are most likely to be in the right mainstem bronchus, followed by the left mainstem bronchus, followed by the larynx or trachea. On these examinations, the arrow points to a very fine foreign body in the area of the vallecula. On a different patient, a radiopaque foreign body in the lower airway with the pathologic specimen. This finding secondary to a fish bone. These are a chicken bone, and this is a foreign body in the airway. Remember that not all foreign bodies are radiopaque, so you may search for them and not find them. A metallic foreign body seen in FOSS, which is actually partially corroded. Again, here in a different patient, and another foreign body posteriorly here. The presentation of the foreign body in FOSS tells you where it's located, and the foreign body may compress and displace the trachea anteriorly. The foreign body itself may corrode or erode, as in this case, with current pennies, which are zinc but only copper coated. Batteries, you may find the same finding. And here we have a radiopaque foreign body, metallic, which is actually eroded through the esophagus itself. You can see the barium column, and a separate column on the other side, which is secondary to abscess formation. Here we have a toothpick posteriorly, which has caused mass effect, swelling, and inflammation, and has partially closed down the airway. Make sure that if you identify what you think, as in this case are pennies, or in other cases batteries, they're removed because, as I said, they're caustic. They can erode and corrode themselves. And if you see what appears to be a penny, a nickel, whatever, a coin and FOSS, that's going to be in the esophagus. Next, we're looking at soft tissue mass in the right upper lung field and mediastinum, shifting the trachea to the left. The trachea in children, remember, is usually in the midline or slightly to the right. On the lateral projection, a large soft tissue mass displacing the trachea anteriorly, and in a different patient, an enhancing soft tissue mass behind the trachea, just anterior to the vertebral bodies. And please remember to look on your bone windows to make sure that there's no infection, osteomyelitis of any bony structures. These masses cause varying amounts of compromise depending on their level. They are secondary to bacterial infection, but can be less likely due to a penetrating foreign body as seen previously, which subsequently infects. And these are retropharyngeal abscesses. Three different patients. On a frontal view of the chest, a mass in the apex, a large cyst inferior and posterior to the jaw, and a multiseptated mass on an MRI examination. These are congenital malformations of the lymph sacs and most commonly involve the posterior triangle of the neck and the supraclavicular fossa. While they're histologically benign, they may infiltrate into surrounding tissues, including the retropharyngeal space and mediastinum, and this is a cystic hydroma. Finding on the left shows an increase in tracheal dimension greater than 2 standard deviations above the mean. It's sometimes seen in prolonged ventilatory support or chronic infection, including cystic fibrosis. The finding on the right is actually the opposite, marked narrowing of the trachea. There's also, in this case, a right upper lobe bronchus arising directly from the trachea, which may supply the complete right upper lobe, an apical segment, or a supernumerary segment. The incidence is about 1% in the general population. So this is tracheobronchiomegaly, And this is tracheal bronchus at the same time with tracheal stenosis. A diagram here that tends to drive a lot of folks nuts because you have to try to remember exactly what's happening and where. So we're looking at a lateral projection. Here's the spine, the esophagus, and the trachea. Posterior indentation on the esophagus, anterior impression upon the trachea. And this is a double arch or a right arch with the left subclavian and left ductus, which is usually symptomatic. On the next, we have anterior impression upon the trachea, which is secondary to an anomalous innominate artery or anomalous left common carotid artery, which is usually asymptomatic. The next case, posterior impression upon the esophagus. This is secondary to a left arch and aberrant right subclavian or right arch and aberrant left subclavian artery, usually asymptomatic. And on the right, posterior impression upon the trachea, anterior impression upon the esophagus. The structure in question comes between the two, and this is secondary to a pulmonary sling, which is usually symptomatic. So the drawing here on the left, which is a little bit too pretty and perfect. The findings seen on the right, mass partially compressing the trachea. A similar mass, but smaller and more inferior on the left, also compressing the trachea. The mass on the left is often small and atretic. On an esophagram, you will see an impression from superior right to inferior left. Let's go back. And on the lateral projection, an impression upon the posterior esophagus. Axial MR shows the large right vascular structure and the smaller left vascular structure surrounding the trachea. The coronal MR shows narrowing and compromise of the airway with the larger right and smaller left structure approximately at the same level. And a coronal CT, which shows a large right vascular structure superior to a smaller left, partially atretic structure with compromise of the airway, and this is a double aortic arch. The drawing here shows the idea of the main pulmonary artery. Instead of giving off the left pulmonary artery, it gives off the right, which then gives off the left. On the axial projection, you see, once again, the main pulmonary artery giving off the right, which gives off the left, which travels between, always, the trachea and esophagus. On the coronal DSA projection, you can see marked stenosis of the trachea. Also, there's a relatively horizontal course and lower origin of the right mainstem bronchus and a lower than normal left hilum. Going further on the chest x-ray, we see increased lucency of the left lung, secondary to the left main pulmonary artery being compressed between the trachea and the esophagus. Here on the lateral projection, we actually see the structure coming between the trachea and esophagus with the posterior impression on the trachea, the posterior impression on the trachea, the anterior impression on the esophagus, and on the esophagram, the mass impression upon the anterior esophagus. For MRIs, MR coronal, the right pulmonary artery giving off the left. In this case, here's the the left pulmonary artery coming behind the trachea and compressing it. Here's the beginning of the left pulmonary artery coming from the right. And in this case, we can see the right pulmonary artery giving off the left and causing marked compression of the trachea. And this is the pulmonary sling. Next case, the drawing here on the left, the findings on the barium esophagram on the right, impression from the inferior right to the superior left, although the patient is slightly oblique, but it's still going to be inferior right to superior left. The posterior impression upon the esophagus. The MR examination. And this shows not a double aortic arch, but a right aortic arch, a large left ductus. Once again, the right aortic arch, a very large left ductus coming behind the trachea. And on the sagittal projection, this is the large ductus coming behind and compressing the trachea. And this is a right aortic arch with an aberrant left subclavian artery, which generally has a left ductus, which causes a ring, but this is usually asymptomatic because the ring is loose. However, it may become symptomatic or may be symptomatic if it's associated with a large aortic diverticulum. Imaging shows a large posterior impression on the esophagus on the lateral projection and an impression on the AP view from the inferior right to the superior left. Radiographic findings in this case show loss of the fat stripe on the right, no obvious aorta on the left. Other findings that will be seen, here's an angio. Depending on the modality and the projection, you'll see displacement of the trachea anteriorly and to the left, and a large impression on the posterior esophagus from the superior right to the inferior left. Here you can see the trachea has been shifted slightly to the left, and this is secondary to a right cervical arch. This is more common than a left cervical arch, and is secondary to abnormal development of the arch into the right supraclavicular and neck regions. So that was a quick review of the pediatric airway. I hope this is helpful, and I appreciate your interest, and I hope things go well for you on boards or in practice. Thanks very much.
The subtitle of my talk is Pediatric Genitourinary Radiology's Greatest Hits. The reason that I like to think about that for this lecture is that this topic is so broad that there is absolutely no way that I could cover all of it. So my goals today are to review with you the congenital renal anomalies that are the most testable items for your boards, and I'll be spending most of my time talking about these. I'm also going to touch on acquired anomalies, including infection, and if time permits, I will talk about renal masses. If you look in your handout, there's a lot of information, and all of the words that I have on the PowerPoint presentation are in the handout, so you don't really need to follow along right in your handout. If you could look at the slides that I'm showing you, and maybe some of the words will pop into your head, and then you'll be able to apply them to the images, and you'll be very far ahead of the game for your boards. So first I'm going to talk about anomalies of position, fusion, and rotation. Ectopia occurs when there is failure of normal ascent of the kidney to the location right below the diaphragm by 8 weeks of gestational age. If you remember, the blood supply of the kidney is at the level that the kidney is. So the kidneys initially have their blood supply from the iliac vessels, and as the kidney ascends, the kidney parasitizes vessels all along the way, so the vessels move with the kidney. Now, a kidney in an abnormal location will then have blood supply at the location where it is. So a pelvic kidney will have iliac blood supply, an iliac or a lumbar kidney will have blood supply from the aorta at a lower level. The kidneys that do not ascend to the appropriate location are slightly dysmorphic, and they have more anomalies than a normally positioned kidney. They are also subject to trauma. Crossed ectopia occurs when the kidney crosses the midline. Okay. A sign that's very important for you to know is called the lying down adrenal sign. This can be observed antenatally, and what we see is that the adrenal gland occupies the renal fossa, and its shape is abnormal. It's elongated and appears much larger than you would expect it to be. The adrenal gland arises just below the diaphragm, and to form a normal shape, the kidney must intersect the adrenal. So when you see this elongated adrenal, you have to start thinking, what's the problem? Where's the kidney? So you have to go and look for a kidney. The kidney may be absent or it may be ectopic. An absent kidney is called renal agenesis. It's a fairly common anomaly occurring in 1 in 1,000 births. The ureter itself is usually absent, and the ipsilateral trigone and ureteral orifice are absent as well. The adrenal gland may be absent in 10% of these patients. And if you remember, this can be associated with GU anomalies. In boys, you can have seminal vesicle cysts. You can have absence of the ipsilateral seminal vesicle. You can also have absence of the vas deferens. In girls, Mullerian anomalies occur. And so what we look for are obstructed vagina, duplication of the vagina. The example on your right shows the lying down adrenal sign. You can see this beautifully elongated adrenal gland with the echogenic central portion and the hypoechoic area around it. I call that the Oreo cookie sign. And if you look at the lower image, this is a sagittal view, and we see the urinary bladder anteriorly, and posteriorly we see a fluid-filled, elongated structure, and this was an obstructed hemivagina in a girl with renal agenesis. The slide on your left is a sonographic examination showing crossed ectopia. We can see 2 kidneys, and they're touching, they're kissing kidneys. With crossed ectopia, there may be partial fusion or complete fusion. The slide on your right is from an excretory urogram, an IVP. We don't do those very often anymore. And if you look, you can see this is the left kidney, which has ascended appropriately, and the lower kidney is the right kidney that has crossed the midline. The ureter for the right kidney is in the expected location on the right side of the bladder. I'm going to talk a little bit about fusion abnormalities. I've already touched on crossed ectopia, where fusion may be partial, complete, or not at all. When the kidney is ectopic or there is a fusion abnormality, the ureters are not ectopic. The example of fusion abnormality that you are most familiar with is the horseshoe kidney. Generally, in a horseshoe kidney, the isthmus is located at the lower poles of the kidney, and it may be composed of functioning parenchyma, or it can be composed of fibrous tissue. The kidney ascent or migration to the normal position is stopped by the inferior mesenteric artery. As with other kidneys that are abnormally positioned, the horseshoe kidney is not quite as good a kidney and is slightly dysmorphic. There may be more anomalies. You can have UPJ obstruction, reflux. Infection occurs more commonly, most likely due to reflux. There are more calculi. This type of kidney is subject to trauma, and depending on what literature you read and believe, some authors indicate that tumors such as Wilms tumors and renal cell carcinoma are more common in horseshoe kidneys. A type of kidney that is a fusion is called a cake kidney, and you may not see this as often as you see a horseshoe kidney, or you might think that this is a horseshoe kidney, but it really isn't. And what we see on this sonogram on the left, we see a kidney, and it's not as quite as beautiful as you would expect it to be. The medullary pyramids are not quite as hypoechoic and attractive. If we do look at the kidney on the right-sided image and we see it, it looks more like a lump. And this is a fusion of pelvic or iliac kidneys. And this is either called a cake kidney, and some people do call it a lump kidney. Okay. When the kidneys ascend from the pelvis to the renal fossas, initially the renal pelvis are pointed anteriorly, and as the kidney ascends, the pelvis rotates so that the pelvis point towards each other, and sometimes this fails to happen. And the example that I'm showing you on the right-hand slide, if you look at the CT examination, you can see on this delayed image of the kidneys that the renal pelvis points anteriorly instead of medially. The kidney on the left is obstructed. This is a UPJ obstruction, and this renal pelvis is also oriented anteriorly instead of medially. So this is a failure of normal rotation. So it's an absence of rotation, not really a malrotation of the kidney. The image on the bottom slide is in the same patient, and this is from an excretory urogram, and if you look at the right kidney, the calyces appear to be pointing both towards the midline and away, and the renal pelvis is very poorly defined. So that's your sign that the kidney has not rotated properly. And the UPJ obstruction, again, we see on the left side. I'd like to talk about ureteral duplication next. Ureteral duplication may be partial or complete. We see partial duplications commonly, and some people think of these as the most common normal variant. The partial duplication that we see and just brush off all the time is a bifid renal pelvis. That's the first attempt at duplication. And if you look at sonograms of the kidney, sometimes you'll see something that's called a fibrous cortical defect or a junctional parenchymal defect. I'm sorry, it's not a fibrous cortical defect, but a junctional parenchymal defect, and that's a connection between the capsule of the kidney and the renal sinus, and that's one of the first attempts at forming a ureteral duplication. When there are two separate ureteric buds intersecting the metanephric blastema, a complete duplication will occur. Now, I'd like to stress what the Weigert-Meyer rule is. It states that in a complete duplication, the upper pole ureter inserts inferiorly and medially to the lower pole ureter. The lower pole ureter is the orthotopic ureter, the ureter that is located in a normal position. This upper pole ureter is more likely to obstruct, and the lower pole ureter is more likely to reflux. And the reason that this ureter is more likely to reflux is that the submucosal and intramuscular tunnel of the lower pole ureter is not quite as long as it should be. Okay. This is on your left an excretory urogram, and on your right is a delayed image from the same study. And since we don't see these very often and they are boards material, I just would like to review this with you briefly. The right kidney is normal. The upper pole calyces should be aimed towards the contralateral shoulder. The ureter usually sweeps past the transverse processes, and the calyces are delicate. The left kidney is abnormal. The upper pole calyces are directed towards the ipsilateral shoulder, and the kidney appears to be displaced from the spine. If you look at the course of the left ureter, it's displaced from the transverse processes. And that's because there's a duplication, a complete duplication on the left side. If you look at the image on your right, you can see the upper pole system, and it's markedly dilated, and the ureter is very tortuous and dilated as well. So the two ureters are doing a dance or a fandango, and if you put the two images together, you can understand how the complete duplication on the left side fits together. Okay. These complete duplications are more common in girls. If there is reflux, lower pole reflux, it may be outgrown the same way that reflux in single systems is outgrown. In girls, the ectopic ureter can insert either above or below the sphincter. If it inserts below the sphincter, the girl will have constant dripping. She'll never be dry. The ureter could go to the perineum. It could go to the uterus. There are many locations. Even though the upper pole renal parenchyma doesn't function so well because it hasn't been formed normally, it still makes enough water so that her panties will always be wet, and you need to know that that's what you're going to be looking for. Now in boys, the situation is different. These ectopic ureters insert above the sphincter, so the boys are dry. The upper pole ureter can also go to a lot of locations in boys, and one that I'd like you to remember is that it may go to the epididymis. If it inserts on the epididymis, then epididymitis may be a presenting symptom of someone with an ectopic ureter. Now, just to expand ectopic ureter, there's something that's called an ectopic ureterocele. That's when an ectopic ureter has an orifice where there's been an abnormal formation or recanalization of Schwalle's membrane. And so the ureter actually extends into the urinary bladder, and what happens, these ureters tend to obstruct very commonly. A normal upper pole ureter an upper pole ureter without a ureteral seal will obstruct as well, because those orifices are usually stenotic, but these ureters that are subtended by ureteroseals tend to obstruct commonly. And the system that it's associated with is usually very poorly functioning. This is a sonographic example of ectopic ureterocele. The image on your left is a sagittal or longitudinal view of a kidney, and what we see is a cyst in the upper pole. And this is the obstructed upper pole moiety. And if you look at the image on the right, there appears to be a cyst or a little balloon inside the bladder, and this is the ectopic ureterocele. These come in different flavors or varieties, and if you look at the image on the left, you can see that the ureterocele is very large. When they're quite large and they're located inferiorly, they can be called cecoureteroceles, and then those tend to obstruct the bladder. They can actually fall into the bladder neck with voiding, so they can be a very big problem. The image on the upper right is an ectopic ureterocele, and if you look, it contains debris. These systems are obstructed. They may contain precipitates. They could have blood or pus behind them, so that's not that unusual a finding. The ureterocele in the lower right-hand corner is collapsed. If you watch these under sonography, they fill, they collapse, and you have to be careful because if you look at just this one image in the lower right-hand corner, you could think, oh, there's some type of mass in the bladder. Is it a tumor of some type? Is it a rhabdomyosarcoma? Is it an inflammatory pseudotumor? Is it some type of other lesion? Is it a blood clot? So you have to observe these under real-time examination. I'd like to start talking about antenatal hydronephrosis right now. This is one of the most common reasons that we do imaging in infants. The patient frequently comes to us with a diagnosis of antenatal hydronephrosis, and we usually don't have very much information. We have no idea, is it 5 millimeters at what week? Is it 9 millimeters? There's very little information. So most people have their patients get a combo exam, ultrasonography, and VCUG. You could, depending on what you believe, you could do the ultrasound right on day one of life. If you see something abnormal, then you can continue with your workup. If you do an ultrasound on day 1, 2, or 3 of life, you may not see an abnormality. The newborn is quite dehydrated and urine production is lower. GFR increases with age, so if the examination is normal on the first several days of life, you may want to bring the patient back at about 6 weeks of age and do another sonogram. So routinely we do ultrasonography and voiding cystourethropy in these patients. I'm sure you've had time to read what the differential diagnosis or considerations in antenatal hydronephrosis. Prenatal sonography is very, very good. However, we don't always have the diagnosis. That's why we have to perform imaging after birth. Okay, the first entity I'd like to speak about is the multicystic dysplastic kidney. This is a non-functioning kidney due to early and complete obstruction at the ureteropelvic junction. As Dr. Fernbach mentioned earlier, on prenatal sonography, some things just disappear. Sometimes, as with cystic adenomatoid malformation, the cysts get much smaller over time, or with infradiaphragmatic bronchopulmonary sequestration, those tend to disappear. Sometimes these multicystic dysplastic kidneys get much, much smaller during gestation and can actually disappear completely. The renal artery and vein are either atretic or hypoplastic, and there is a contralateral anomaly in up to 40% of these children. I always stress with my residents that you have to do a VCUG in these patients because there's a very high incidence of reflux, both ipsilateral and contralateral to the lesion. And if you have a solitary kidney, you certainly would want to be on antibiotic prophylaxis if there were reflux. So performing a VCUG is essential in these patients. Now, the sonographic description of multicystic dysplastic kidney is very straightforward. We see multiple cysts of varying sizes. These are arranged randomly, and there is scant parenchyma. So if we look at the image on the right-hand part of the slide, we see a very large cyst in the upper pole, two smallish cysts in the mid portion, medium-sized cysts, and multiple cysts in the lower pole. Notice, though, that this isn't completely a cystic mass. There are also areas of hyperechoic parenchyma associated with it. Now, if you think it's a multicystic dysplastic kidney, or if you're not sure, you need to do some other imaging studies. There's two different types of multicystic dysplastic kidney generally. There's a hydronephrotic form, which looks like a UPJ obstruction, and then there's a form that's kind of a bunch of grapes or a Bacteroides type of form. And sometimes you'll look at an image and you'll have no idea what it really is, so you need to do a little bit more work. And what we like to do are nuclear medicine studies. The pair of images on your right shows a kidney which looks a little bit not quite like a classic multicystic dysplastic kidney. There's a lot of parenchyma centrally. The cysts are located peripherally. The nuclear medicine study below that shows that there's no kidney on this side, whereas there's a kidney contralateral. So if there's no function, then you know that it's a multicystic dysplastic kidney. Most hydronephrotic kidneys from UPJ obstruction or ureterovesical junction obstruction will have some function. Okay, then I have a collection here of varying looks of multicystic dysplastic kidney. On your left is more the bunch of grapes type. Many cysts, varying sizes, arranged randomly. In the middle on the top, some larger cysts peripherally, some small cysts centrally. The slide on the bottom, another look. The image on your right shows the cysts looking very tubular. So these are all different multicystic dysplastic kidneys. Over time, these tend to stay the same size or they involute. They're usually leave-me-alone lesions. There have been some case reports of Wilms tumors developing in these, or these can be the result of hypertension, but most people tend to do watchful waiting with these. If they're so large that they compromise lung ventilation, fluid can be drained from these.